for recognizing the face of hope. We will be talking about some of the recent challenges from the pandemic that have impacted social determinants of health. We will highlight some of the legislative efforts being proposed to improve these challenges. And we will share some examples of field-based case managers and their experience supporting community-based Medicaid members during the pandemic. My name is Tim Conner. I'm the National Vice President of Government and Healthcare Partnerships with Mom's Meals. I work on national policies and programs supporting food security for Medicaid and long-term care recipients. My co-presenter today is Tara Searles, who is the Director of Healthcare Partnerships with Mom's Meals supporting national Medicare programs. Tara brings a unique experience as a member, advocate, former case manager, and also her leadership work in operations for a health plan. Real quickly, for those of you who do not know what we do, Mom's Meals is a national home delivered meal provider. We work for both state and federal policy issues to promote paths for covered meal benefits in support of Medicaid, Medicare, and community-based government programs. We advocate for member-centered outcomes by providing choices of menus that meet the unique taste preferences, health condition needs, and cultural needs of our communities around the country. We are currently supporting innovation with many of our key health plan partners to address the food insecurity and health inequity challenges we will highlight today. Let's review some of the social determinant challenges exacerbated by COVID-19. While hunger is not a new concept to any of us, we all know stories or have seen challenges that social isolation and COVID-19 have caused and are seeing alarming new indications of how fragile food security is for millions of Americans. End of the day, what can each of us do to bridge the gap in social programs? Funding was expanded for many of these programs, but food insecurity rates continue to rise. What is a practical way to reduce the rates of food insecurity and drive the outcomes and innovation that our society needs to truly make an impact? Over the past 3 years, both rates of poverty and food insecurity have increased, even while jobless rates have not. What does this tell you about the challenges our most vulnerable communities face? Poverty and food insecurity have both increased to an average of 12% of our population, even as flexibilities in EBT programs and other benefits have been provided on the national level. What have we learned from this, and what can we do to address these health inequities in areas that have all continued to fall behind? On the right side of your screen here, COVID-19 has seen disastrous effects on our most vulnerable communities with reduced access to food, increased social isolation, challenges to employment, housing instability, and changes in how we access healthcare. As I mentioned, our most vulnerable populations fare the worst. Older Americans, individuals with disabilities, and those with pre-existing and underlying health conditions all are at higher rates and risk of exacerbations to their health and well-being. Studies have also shown those groups most vulnerable include the elderly, racial and ethnic minorities, people living in rural communities, individuals with disabilities, the homeless population, those that are pregnant. As we just discussed, racial disparities in food access and health and nutritional security stands out as a call to action for all of our communities. The rate of food insecurity for Black households is twice the national average at 21.2%, whereas Hispanic households still high at 16%. So what are the causes of all this discrepancy? Research has shown these households are also more likely to live in a food desert, having less direct access to a full-service supermarket. Limited funds without access to full-service grocery stores will not result in a consistent purchase and consumption of healthy and balanced nutrition. Studies from the pandemic have highlighted these households are even less likely post-pandemic to be able to afford and access healthy and balanced food sources. So where do we go now? As we address rising rates of the Delta variant and ongoing challenges post-pandemic, all of us working together to identify the best way to support high-risk community-based populations will be critically important. We wanted to share a few examples of some legislative efforts that may supplement your programs or communities and to drive the pursuit of health equity for these high-risk communities that we're talking about. Some of these efforts are needed to supplement lagging community-based programs that are still not in line with some of the pre-pandemic levels that we've experienced. The American Rescue Plan Act of 2021 is currently law. Each state across the country has responded to a CMS request for clarification on how money will be spent toward your HCBS communities. Although each state is different, the federal projected spend will approximate $750 million for meals for older adults and other programs like Grab and Go, whereas the additional $659 million toward home and community-based services, including jobs programs, technology, things like disease prevention, caregiver support, and investment into long-term sustainable funding. So how do health plans and providers partner with each of our state DHSs to commitment and our commitment to innovate, right, these home and community-based service programs to ensure expected outcomes from CMS and reductions in the health disparities that we have all discussed today. Some other home and community-based programs include the COVID HCBS Relief Act, which increases the FMAP under Medicaid HCBS to improve issues compounded by the pandemic. The American Jobs Plan is currently proposed and offers $400 billion for expanding HCBS and Medicaid, along with increased waiver programs. The HCBS Access Act is still being developed, but this would require states to cover home and community-based services in Medicaid as a mandatory benefit with 100% FMAP. Although there are many bills focused on maternal health, we wanted to highlight one particularly which has taken some traction to address minority health disparities. The Black Maternal Health Momnibus Act of 2021. This is intended to focus efforts around social determinants of health and expanded payment models for these social services. Additionally, it focuses on establishing a new CMS Innovation Center to address issues promoting health equity and improve maternal health outcomes for low-income and minority communities around the country. From a more general social determinants of health concept with focus on nutrition, the Medically Tailored Home Delivered Meals Demonstration Pilot Act of 2020 is being introduced in August. This would require CMS to establish a demonstration program allowing hospitals to provide medically tailored meals to Medicare beneficiaries with chronic disease. I know a lot of the programs we talk about are Medicaid driven, but we'd like to highlight any program that really drives the access and promotion of food security for our high risk and most vulnerable communities. Please share any questions in the chat as we talked about. We can address at the conclusion of our presentation, but I'll hand it off to my colleague, Taryn.
Thank you, Tim, and good afternoon, everyone. So excited to share with you some results from a survey we did recently. We understand how important case managers and care coordinators play in identifying food insecurity. So we asked, how has that role changed in the COVID era? Feeding America shared that in the US alone, prior to COVID-19, more than 35 million men, women, and children faced food insecurity. And since the onset of the pandemic, the number is projected to increase more than 42 million, which includes 13 million children. So really our quest for the survey was just to understand how that role has changed and maybe to have some insight on how we can support and break down the barriers that might exist. Next slide, great. So the overview of the survey, the objective was really just to assess that case manager perspective and look at the experiences regarding how the pandemic has impacted assessment, support, and food insecurity. We had the survey open July 20th through the 23rd of this year. So I would like to note that the Delta variant may not have been as prevalent when people were answering the survey, so just something to keep in mind. We sent it via an online survey. Through email, we had 150 responses, but we did send it out to over 1,000 case managers nationwide. Our responses were mainly from the health plan MCO space at 39%, Office of Aging with 31%. Our community-based organizations and nonprofit responses were about 9%, and then other was about 21%. And just the other being nursing home, transitions care, really any of our field caseworkers. And then the next question we really kind of went into was, what did caseload sizes look like prior to the pandemic and currently? So you can see that in that first column, the highest caseload for both prior to the pandemic and currently are in the 0 to 50 client caseload range. So that's pretty average across previously and now. We also note, though, that the biggest increase from prior to the pandemic to currently is those that have greater than 100 clients in their caseload. And you can see that that increased 5% to 15%. Caseload capacity depends on so many various factors, including how complex are the cases, where are the clients located, are they in a rural area versus a populated area, and is the care manager seeing the member in the home or telephonically? So the following slides gives us more insight into the complexity of how their roles have changed. Another look at caseloads provides insight into adequate time to assess and support a client in the current state. So data shows that 50% of care managers believe that they do have enough time or they have plenty of time. but 50% of care managers believe they need more time to analyze risk and support their clients. Of that lower 50%, 20% stated they have rarely enough time. So during a time when clients are more vulnerable than ever, adequate time to assess client needs is critical. We know that time and patience is what's necessary to establish trust and rapport so that we can truly understand the needs of the client. When 50% of the care managers are stating there's not enough time, my thoughts go to what is potentially being missed in that critical assessment period. And then add on to that any barriers communicating over a phone when you don't have the eyes and the ears in the home, and you might miss sometimes what's truly being needed. For example, the power's turned off, and so there's no food in the fridge. You may not know that unless you've got eyes in the home, or there's fast food wrappers all over and no fresh food. So when you ask, do you have food at home? They may say yes, but it may not be the nutritious food that's going to support their health and well-being. So when is the last time you've seen a majority of your clients face-to-face? So this question, we were really looking just to understand how many folks are in the home, back in the home, and what does that look like? And really, it was kind of interesting to see that a lot of folks, about 21%, have seen a majority of their clients face-to-face. That does not mean they've seen all of their clients. It could mean that they've seen the sickest of their client base or those that have requested them to come visit. 3% were in the past 6 months. They saw a majority of their clients. And then within the past year, about 7%. And then 69% that it's been over a year that they've seen majority of their clients face-to-face, which is pretty significant when we think about the relationships they had prior to COVID and then having to have those conversations over the phone. So the next question we asked is, if you're planning to return to face-to-face assessments, when do you think this might happen? 40% stated that they've already returned to face-to-face assessments, again, taking into consideration it may not be the full caseload. And 29% said they did not know when they would return. 29% said hopefully August through October. And of course, as I mentioned earlier, that Delta variant may cause a delay in that return. So we'll have to kind of wait and see what happens there. And although face-to-face can be easier, care managers really need to take the time to understand how to connect and work with the member telephonically. Often tools like motivational interviewing is going to help that client approach. So helping them to understand what is the client's motivation for change, how to express empathy, how to support self-efficacy, and rolling with resistance. And then recognizing discrepancies over a telephone call versus in person. So lots of changes in how case managers are going to operate and how they're going to communicate and identify and assess. And then the next slide asks the care manager if they currently provide assessments more or less frequently than before the pandemic. 67% of responders shared that they assess their clients about the same as they did before the pandemic. 17% of responders noted that they're assessing more frequently, which is a better outcome than the 8% noting that they're assessing less frequently. As a case manager, one of the main functions is to assess the client situation and individual needs. The good news is that 67% of the care managers are still assessing, and 17% are addressing even more. What previous slides have shown is that they may not have had the same amount of time, and that will kind of minimize what they're getting out of the conversation. So if they only have telephonic means of communicating, the questions become, what are the skills that are required to have those conversations compared to talking to someone face-to-face? And then next slide. Oh. So let's see, food insecurity and nutritional risk before pandemic and currently. So now we're looking at really, is there more of a risk now, or was there more of a risk prior to the pandemic? And 52% of responders noted that the risk was about the same. 28% said it's higher now, and 12% said it's lower. what's significant is that the 68% of responders who have more than 100 clients stated that they're at a higher risk now versus only 21% of others 0 to 100 clients. So identifying the risk, about the same, about half for some folks, but those who have more than 100 clients are saying, hey, yeah, we're noticing this a lot more than we ever did before, which is pretty significant. And then providing assessments more or less frequently. And so this one we were talking about, 2/3 of responders said they're doing it more now, and 17% of responders noted that they're doing it more frequently, which is better than those 8% that said less frequently. And we touched on this one before, but the comments that we heard from the care managers were the same amount, they're doing the same amount of assessment, but it's just over the phone, or CCUs increased in home delivered meal requests during the pandemic, leveling off now, which is good, and that assessment has been related to hospitalizations and need for increased services. So according to case managers, what nutrition services are most important to clients? So the most important services that were identified was the home delivered meals. I think secondary to that was the personal care services and meal prep. And then responders, we did know that responders with 51 to 75 clients on their caseload had the top 3 services all about even in terms of need. And then responders with greater than 100 clients rated EBT food stamps closer to the home delivered meals rate. What's important to note on this slide is that studies have shown that a combination of home delivered meals in addition to the supplemental programs that provide personal care service is truly the most effective and impactful way to support ADLs and promote socialization, which in turn is the most effective way to keep people in their homes and out of the hospital. And then the next slide just gives some anecdotal responses from the survey. Participants totally overwhelmed, working 13 hours a day and sometimes more. That one definitely caught my eye. It's been tough assessing clients over the phone. We have to depend on their honesty and accurate assessment of themselves. I think that's a real barrier for those that are used to being able to look clients in their eyes and understand their needs by looking around their home. Whereas now you really have to trust that the member is speaking honestly, if they're not afraid of, services being called if they don't have food, or they're, possibly embarrassed that they don't have food. So really, that rapport and trust that you can have with the client is going to be key in terms of understanding what actually is needed. And then the last one to note is some of my members got more meals during the pandemic because there was other support, or because they were able to go out and shop. The extra meals made a huge difference. Oh, they were afraid to go out and shop, so the extra meals made a huge difference. Next slide. And
Thanks, Tara.
Tim, if you want to, yeah.
Yeah, and so just a quick summary for this, and again, for all the the health plan partners out there and all those really driving innovation and driving health equity for the members that we all equally strive to support here. Want to just kind of share a quick summary of that too, and part of the dynamic we're looking at right as we emerge from the original part of this pandemic, and as we see the increases in Delta variants. Some of our state governments are starting to put in place some of the same protocols that happened before. What do we really do to drive the access to services and promote the health equity for our most vulnerable communities, like we talked about earlier? And so this survey we wanted to share with y'all just to kind of capture what case managers are seeing. Again, these are Medicaid case managers from all over the country, and all of their experiences, even though each state is completely different, all of their experiences were relatively similar, right? So again, just to summarize that from a face-to-face perspective, more than 2/3 of responders have not seen a majority of their clients in over a year. Again, a lot of these are waiver recipients on the home and community-based service side. That waiver is in place to be a safety net for our most vulnerable communities that are community-based, right? So the fact that 7 out of 10 case managers have not seen these individuals in over a year is concerning, right? And we all know we're doing this for the protection of individuals and reduction of spread of COVID or the Delta variant. But then again, right, how are we ensuring these individuals are surrounded by safety net support when this face-to-face is not able to trigger, right, some of the services that would be beneficial when they see that home environment? As far as returning to face-to-face, 40% of these responders have started to return to face-to-face for their most vulnerable individuals. But what we're seeing at a state level is that's typically for those getting newly enrolled into home and community-based services, which is a great first step, right? But how do we bridge the gap in the lack of face-to-face assessments, and what do we do to support these case managers from a Medicaid perspective or a waiver perspective that are supporting our most vulnerable communities to make sure, again, these safety net programs are in place? And from a social determinant aspect, how do we make sure the benefits most necessary to drive food security and health equity are in place for this population? The majority of responders, 64% of those, are still using phone calls for the assessment period of that interaction. A lot of state governments have waived the need for that face-to-face. Each state is, again, is a little bit different. It might be 90 days, it might be 6 months, it might be annual. But each state has face-to-face requirements as participation of that waiver program. And then a majority of these individuals are still doing it by face. So even though the states, kind of put some flexibilities in place from a necessary standpoint, from a public health perspective, right? That's not allowing us to really capture the risk and the equity challenges that are getting exacerbated by both, obviously, COVID and then the Delta variant spike. And as Tara discussed, home delivered meals ranked by case managers as the highest capacity to provide nutritional support and services to reduce the food insecurity challenge that we're talking about. And again, from a national perspective, right, CMS doesn't limit, right, multiple services for these members traditionally. And so at the state level, right, is there a limitation to making sure, right, let's say there's a flexibility with EBT benefits. Let's say it goes from $50 to $100 during the pandemic, whatever that number is. That in itself is not an outlet to food security and consistency and health and well-being for these members. So the capacity, as case managers kind of see here, the capacity to drive home delivered meals to line around their health conditions and different things that we've talked about really can promote the consistency of that food security for our most vulnerable populations. And we put in here some anecdotal information just to share, because again, we want to celebrate our case managers. They've been on the front line all over the country throughout the pandemic. And as we emerge into this next phase of the pandemic here, case managers report concerns with individuals being supported through Medicaid. And a lot of these individuals kind of slip in through the cracks. We mentioned before, unfortunately, and it's not just home delivered meals, right? Some of these community-based programs have seen a kind of a step back in their utilization across the country. And there's a lot of complexity that leads to that. But end of the day, right, these safety programs that are in place to support our most vulnerable communities, how do we partner to making sure we're driving innovation, getting those to these high-risk individuals, stabilizing these individuals, whether you're on the waiver or whether you're a traditional Medicaid recipient in general, right? How do we make sure all of these social services are supported at the local level to drive the stability that we're all seeking? Tara?
Thanks, Tim. So food for thought, so helping case managers succeed. And this was probably one of my favorite slides, kind of pulling it all together and just giving some food for thought, no pun intended, on what we can do to help our case managers. And like Tim said, they've been on the front line for many months now. And we've heard anecdotally, that they're tired and that there's strain. So just some questions and some next steps for those who are listening today. So a lot of words on the left, but had a lot of things to add there. So we know that assessment is a main function of the case manager role. So understand what the nuances are of an assessment via phone call versus face-to-face. What skills become more necessary in a telephonic conversation, and what barriers might the case manager experience? We talked a little bit about just if the member is embarrassed, or if the member is scared that if they actually report that they don't have food in the home, or other issues going on, that somehow they're going to get reported, or they're going to have to leave their home, which we know is not true, right? We're trying to keep them in the home, but how can we work to eliminate those barriers? Or sometimes, how do we work to hear what's not being said? I think that's a special skill that our case managers have. Motivational interviewing, client empowerment, health coaching, those are now more important than ever before. So how do those tools differ from that face-to-face interaction to telephonic case management? I think you have to be really careful and dedicated to understanding what and how these tools work and how they can be changed or adapted to that telephonic conversation. Something else that I'm very passionate about is how the pandemic has impacted the well-being of so many, especially those in the healthcare field. So as you work with case managers, or if you are case managers, understanding how the pandemic, if you are a case manager, how the pandemic impacted the well-being of that case manager, and how might this limit or improve the case manager's relationship with their clients. And then lastly, home delivered meals were ranked among the highest services to help individuals who on a caseload to sustain food and nutritional security and remain independent at home. So do the case managers know what nutritional support is available to their clients? Are there duplication of service concerns that reduce the flexibility of providing medically tailored home delivered meals? Are there food programs that individuals receive? Are they promoting choice and dignity? And I love that word dignity, and alignment to their local needs, which improves consumption and consistency of food insecurity. I ask these questions so that we can really be aware of what barriers are existing in this pandemic world. And I wish I could say that it's this post-pandemic world, but we're still in it, and we're still trying to figure out the best way to support these clients and the case managers. Furthermore, often telephonic case management creates its own set of barriers, and it doesn't allow for adequate time to fully assess or understand what's going on in that home. So case management is going to rely heavily on the rapport built between the case manager and the client. How to ask the right questions that are going to solicit honest answers from the client. And like I said earlier, that ability to hear sometimes what is not being said by the client. The good news is that we have incredibly dedicated, committed, and empowering case managers in the field. We know that from the great work that you all are doing, from the relationships we have with our health plans and our agencies on aging. So the case manager is truly in that position to build trust and positively impact food insecurity and nutritional risk to support the client. So the more we know what those barriers are, and the more we know what barriers those case managers are facing, the more we can support the community and ultimately impact the client. All right.
Thanks, Tara.
Yeah. So I think now there was a few questions in the chat. So we can pop over there. All right.
I'll cue those up. And everybody, thanks for joining us today. And again, please drop into the chat here any questions. We have quite a few, so we'll start going over these. But if you have any more questions, just drop it in here. And if we miss it, drop it twice so we don't miss your question, please. But first question was from Megan. Are there certain regions of the U.S. or specific states where case managers are feeling more overwhelmed compared to others? Megan, that's a great question. You know what, it was a pretty good spread across because again, each state is different, right? You have your MLTSS states and you have your states that are kind of managed more by state agencies or different organizations from a community-based perspective. So outside of like boxing into that, what we saw was anywhere where the case managers had a ratio of greater than 1 to 75, that's where we saw kind of the pressure start to be more impactful. So especially if we saw a case manager ratio of anywhere from 1 to 100 plus, those are ones where we saw case managers kind of self-reporting, look, I don't have enough time, right? And those are the same groups of case managers that reported that they're unable to drive service continuity and expand like services around social benefits to really make sure these individuals are safe at home. So outside of a regional perspective, right, it was a pretty good kind of consistent answer across the country. But the states that had higher ratios of case managers above 1 to 75, which is usually like the higher level of the cutoff, that's where we saw a lot of those challenges. That's a great question. And Tara, jump in here if you have any supplements and I can move on to the next question.
Yep, feel free to move on. Thank you.
All right, great. Next from Patrick, are there certain regions of the U.S. or specific states where, oh, that's where I just read that one, sorry, that was twice. Sharon asked if there are examples of any home delivery meal programs that are performing face-to-face assessments or other activities to support the case managers. Sharon, that's a great question, right? So again, on the Medicaid side, the structure's a little bit different. During the pandemic, everyone was kind of restricted from doing face-to-face, right? Typically, at Mom's Meals, we have drivers that may be able to go out to the homes and help them get the meals in and do different things, right? We have drivers throughout the country. And then you also have supplemental carriers that kind of supplement those deliveries. But, all those people were restricted from doing face-to-face, unfortunately. I know, like I said, on our side, we usually, on the Medicaid side, we do a touch point with each individual about 4.6 times per month as a national average. So that's somebody reaching out to them, checking on them, seeing how they're doing, making sure they're customizing their meals for them and doing something like that. There are some community-based programs out there, right, that even though during the pandemic, they didn't do a lot of this, a lot of those are volunteer program-based. So if there's an individual at the local level that really needs that meal provider to do a face-to-face assessment, typically you can find that in a nonprofit or community-based organization at the local level. It's not able to scale very wide, but if it's an individual need that someone has, usually your community-based organizations can support that through a volunteer kind of assessment program. That's a great question, though. All right. Mike had asked, what percentage of case managers have access to social determinant of health tools like NowPal or Healthify? Mike, that's a great question. You know, and again, I don't want to default that. It's every state on the Medicaid side is so drastically different, right? So if you break down Medicaid, roughly 4% of Medicaid is home and community-based service waiver, right? And about 10% is LTSS, which means they qualify for that institutional level of care, but they're typically right in some type of institutional care setting. So those individuals typically don't fit into that same kind of assessment tool. For those waiver individuals, that 4% of Medicaid, which is that highest risk population, right? Those programs typically have, right, those health assessment tools and things like NowPal or Healthify or complementary things like that built into their assessment protocols. But outside of that, right, so the general Medicaid population, right, those are deemed a lot different. The waiver members get a lot more aggressive, like case management assessment. So those tools would have to be built into those assessment protocols. And Tara, as a case manager, any thoughts on that?
Yeah, I mean, actually, it's the first time I've heard of those tools. I wrote them down to look them up. But I mean, the fact that those are out there is fantastic, because otherwise you're really relying on your own, assessment tools throughout whatever organization to figure out what the needs are. So yeah, I'm looking forward to looking into both of those.
And to Mike's question as well, right? And that's where, again, I mentioned some of the legislative efforts, right? There's a lot out there. A lot of it's coming back up in August. So we will see what gets picked up on the Hill and what makes it through like various financial kind of reviews for progression, in DC. But one of those we mentioned was the medically tailored meals program. And that would allow, right, health systems for Medicare to, prescribe a medically tailored home delivered meals for those discharging from a hospital. So that's where a community-based assessment, right, whether it's a hospital discharge manager, whether it's a community-based organization at the local level, a case management agency, a AAA, whatever, right, that would tag to hopefully a program like that would trigger that benefit outside of the Medicaid health plan. All right, another question. How can an individual get enrolled with a meal delivery program such as Mom's Meals? Great question, Patrick. So on the Medicaid side, I mentioned at the beginning of the thing, I'll cover Medicaid and then Tara can touch on Medicare, just because clarity around benefit coverage. Historically, there hasn't been outstanding paths to benefits, but I'm really excited that we're seeing over the past 10 to 15 years, a lot of movement there, right? Especially in the pandemic, good, bad, and different about the pandemic. It's created a lot of chaos, but it's also highlighted some gaps in equity that I think help capture, right, innovation around what we're doing. So on the Medicaid side, right, traditional Medicaid doesn't have a path, but a lot of our health plan partners are doing amazing work on innovation, and whether it's, complementing an additional waiver program, but on the traditional Medicaid side, and then with kind of Medicaid and duals in general, those highest risk members that are Medicaid eligible through a health plan, a lot of your health plans are starting to set up innovation tracks to do that. States like California have what's called an ILS benefit, in lieu of service benefit. That's to all Medi-Cal, which is Medicaid in California, are going to be eligible for a 90-day medically tailored meal benefit, right, post-discharge from a hospital. So all the health plans in the state of California are working and building up. Some are doing pilots now, but they're building up to do that. States like Pennsylvania. I sit on with a substantial amount of other people in the managed care plans in Pennsylvania. We sit on health equity regional councils, and we're identifying gaps in service continuity right outside of the waivers where these individuals can qualify for a meal benefit. So that's more done from the state DHS department setting up these health equity committees, and we review that all as a group and identify paths to give benefits to people in need. States like New York are also looking at like that ILS benefit that I mentioned. A lot of states, I live in Georgia. Georgia just passed a 1115 demo for maternal health. Extends Medicaid coverage for pregnant or at-risk moms to receive Medicaid benefits, right, not just right after pregnancy, but postpartum for up to 6 months or a year. All of these programs are ways, but I think it's going to be done through innovation. And that's where I see a lot of our health plan partners really stepping up and really identifying paths to innovation to cover Medicaid, because outside of that Medicaid waiver, which is only 4% of Medicaid, there's not a traditional path to home delivered meal benefit. And that's one of the things our company advocates for. Tara, any thoughts on the Medicare side?
Yeah, I mean, the Medicare side is going to be a lot easier. Typically, it's through a Medicare Advantage plan. So typical, like original Medicare does not cover meal delivery, but Medicare Advantage plans often do have a limited short-term opportunity for when you discharge from a hospital. So it's just going to depend on the health plan. It's going to depend on the benefit, as most things do. But I think I know it's a lot easier for the Medicare Advantage space to have that meal delivery option versus the Medicaid. So usually it's just a matter of finding out what the health plan covers in terms of the meal benefit.
Yeah, I think end of the day, Patrick, too, right? If they have a health plan, whether it's Medicaid or Medicare, right, their health plan case manager should be able to line them with an available benefit.
Yep.
I know that's the best
That's
path
right.
on the waiver side, but we're also seeing again, I mentioned before in that legislation, there's a lot of Older American Act kind of modernization discussion happening right now. The OAA puts a substantial amount of investment into community-based organizations, area agencies of aging, like Tara touched on before, which are some of our respondents as well. So outside of the Medicaid or the health plan space, community-based organizations do get funding from the federal government or from their county governments or state governments to set up various types of nutrition programs. They may be home delivered meal programs, they may be adult daycare congregate sites. There's a variety of things emerging right now, but we're seeing a modernization of that post-pandemic where the things we just talked about today from our case managers, right? What's really valuable? What's a tangible way to make an impact from a nutrition standpoint and sustain that and keep these individuals in the community and improve that health equity? Those are what we're seeing the modernization around. So those are great questions. Hopefully that answered your question there. One more question I saw was from Beth. I mentioned a decline in community-based services. Can I elaborate on that? Yeah, Beth, that's a great question. So again, I mentioned the pandemic, and I'll go in a little bit deeper about this. On the Medicaid side, like we touched on, roughly 4% are HCBS eligible for those meal benefits, right? Outside of that, it's per health plan or per community based on what the local market will allow. But with that, we did see, and this is where services across the country, that's where with all of the flexibilities that got kind of, I guess, encouraged or pushed from the federal government down to the local level, I mentioned before, although amazingly beneficial, right? The EBT and SNAP benefits that expanded across the country. And that's a very valuable thing from the Department of Agriculture that gets, again, pushed down to the state and to the community level to support right, community food banks and different things and accessing food banks. That is very valuable. Unfortunately, in some of our communities, the expansion of that flexibility would kind of disqualify them for programs like home delivered meals. And that's what I mentioned before. It's not just about medically tailored meals or home delivered meals. When the federal government puts temporary flexibilities in place, right? I think part of our advocacy as a company is to make sure we say, look, right, let's partner with our health plans, let's partner with our AAA's community-based organizations, right? Temporary flexibility should not disqualify somebody based on a duplication of service concern. So that's where we all partner together, right? As a society, we partner with our great health plan partners out there, our Medicaid partners, we partner with our DHS leads and make sure when they're putting out these programs and increasing flexibilities, that the existence of a supplemental federal benefit should not replace some of these state Medicaid waiver or state Medicaid programs that are in place to support health equity. But hopefully that makes a little bit better sense. That was a great question. Thank you. Any other questions or comments before we wrap up? I think that was it so far. We'll give you just another second here and then we'll call it a day. We appreciate everybody joining us today. Anything else? All right. So thank you, everybody. Thanks for joining us today. If you're part of a health plan or a health system or anything that you're doing with, throughout the country from a social determinant aspect, we can share these slides. We can support any innovation. We're working with a lot of our Medicaid health plans right now to really set up tracks for innovation. CMS likes to see that, right? Centers, for Medicare Medicaid Services and CMMI likes to see innovation throughout the country. So it's just a friendly kind of challenge. If there's health plans out there that really see opportunity to drive innovation, challenge providers like us to really support you through that. We've seen the capacity of these medically tailored meals to really produce a specific outcome to reduce the health disparities that we're talking about today. And most specifically, just those that were highlighted through the exacerbation of the COVID pandemic and the rising Delta variant out there. So we thank you all for joining us today. If there's anything we can do to support you in the future, let us know. But we hope everybody has a great day and thanks for your time.
Okay.
Turn it back over to Patrick.
Thank you.
Thank you, Tim and Tara. That was very informative, very valuable. Hey, thank you to our attendees for not only coming to this, but your participation. Your questions were fantastic, and it really adds to the discussion. So thank you for that. And as a reminder, attendees will receive today's slides upon request. You can see the contact info here if you'd like the slides, and we'll get you a link to the YouTube channel with the presentation. If you have any questions, follow-up questions, of course, I'm sure Tim and Tara would be happy to follow up. So just shoot them an email. And thank you, Tim HPA Silver Partner, Mom's Meals. They've been, like I said before in the intro, a long-time supporter and partner with our health plans and have provided great service and support. So we appreciate that. So with that, I'm going to wrap things up. We will have future Wednesday webinars, so free to share them with your colleagues, and you'll receive emails from us. Thank you all. Have a great Wednesday afternoon.
Thank you.
Thank you.